If you are watching this video, there is a good chance you are tired. Maybe you have been tired for a while. You have probably already Googled how to sleep better at 2 in the morning. You have tried the lavender pillow spray. You have tried the melatonin. Maybe you have tried just pushing through, telling yourself you will catch up on the weekend. But here is the thing. Sleep deprivation does not fix itself on its own, and it does not respond to the same approach in every person. What works for one person can make things worse for another. I'm going to walk you through everything the research currently tells us about how sleep deprivation is treated. From the most effective behavioral therapies to some genuinely surprising findings about depression, the gut microbiome, and how the brain responds to controlled sleep loss. This is not a tips video. This is a complete evidence-based breakdown. The kind of information you would get from a well-informed clinician, not a wellness blog. By the end of this video, you will understand why you may not have found relief yet, and exactly what options are available to you. Before we get into treatment, I want to say one thing clearly. Poor sleep is not a personal failure. It is not laziness. It is not weakness. It is a health condition that has real, treatable causes. And the fact that so many people suffer silently is a gap in public health education that CareThrive exists to close. Everything in this video is grounded in peer-reviewed research. I will explain what the evidence actually shows, including where it is still evolving. Let us get into it. The single biggest mistake people make when trying to treat sleep deprivation is reaching for a solution before understanding the problem. Sleep deprivation is a symptom as often as it is a standalone condition. Treating insomnia in someone whose sleep is being disrupted by untreated depression is like treating a fever without looking for the infection. So before anything else, what is actually driving your sleep loss? Let me walk you through the 5 most common categories. First, chronic insomnia. This is difficulty falling asleep or staying asleep that has been going on for at least 3 months, at least 3 nights a week, and is causing real daytime impairment. This is the most common sleep disorder in adults, affecting roughly 1 in 10 people. Second, depression and anxiety. Mood disorders are among the most powerful disruptors of sleep architecture. Sleep and mental health affect each other in both directions, and treating one without the other rarely produces lasting results. Third, sleep apnea and other sleep disorders. If you are sleeping what feels like enough hours, but waking up exhausted, or if you snore heavily or wake gasping, sleep apnea needs to be ruled out. No behavioral intervention will fix a structural airway problem. Fourth, poor sleep habits. This is often called sleep hygiene, and while it sounds basic, the research shows that many cases of insomnia are maintained by behaviors that can be changed. And fifth, acute situational stress, a life event, a major transition, a period of crisis. This kind of sleep disruption usually resolves when the stressor passes, but sometimes it does not, and it becomes the starting point for chronic insomnia. Knowing which category applies to you, or which combination, is step 1. And ideally, that assessment happens with a healthcare provider. If you have been struggling for more than 4 weeks, that conversation is worth having. With that foundation in place, let us talk about the treatments themselves. Starting with the one that has the strongest evidence base of any approach, CBT-I. CBT-I, Cognitive Behavioral Therapy for Insomnia, is the gold standard treatment for chronic insomnia. It is recommended as the first-line intervention by sleep medicine organizations in the United States, Europe, and the UK. Not sleep medication, not supplements, CBT-I. And yet most people who struggle with insomnia have never heard of it. CBT-I is a structured program, typically 6 to 8 sessions, that works by identifying and changing the thoughts and behaviors that are keeping you awake. It does not just teach you relaxation techniques, it actually rewires how your brain relates to sleep. Let me break down what CBT-I actually involves, because most people are surprised by some of these elements. The first component is sleep restriction therapy. This sounds counterintuitive. When you are already sleep deprived, the last thing you want to hear is that you should spend less time in bed. But here is the logic. If you are lying in bed for 9 hours and only sleeping 5 of them, your brain learns to associate the bed with wakefulness. Sleep restriction temporarily compresses your sleep window to match your actual sleep time, building what researchers call sleep pressure until you are sleeping efficiently again. Then the window gradually expands. The second component is stimulus control. This is about retraining the association between your bed and sleep. The rule is simple but powerful. The bed is for sleep and intimacy only. No screens, no working, no lying there anxious and awake for an hour. If you cannot sleep after about 20 minutes, you get up and do something calm in low light until you feel sleepy. Then you return. Third is cognitive restructuring, identifying the unhelpful beliefs that feed insomnia. Thoughts like, if I do not get 8 hours, I cannot function, or I am a bad sleeper, or I will never get this under control. These thoughts create the anxiety that maintains insomnia. CBT-I teaches you to examine and challenge them. Fourth is relaxation training, breathing techniques, progressive muscle relaxation, body scans. These reduce the physiological arousal that makes it hard to fall asleep. And fifth is sleep hygiene education, the foundational habits, consistent wake time, light exposure, caffeine cutoffs, temperature, and more. The evidence for CBT-I is remarkable. Studies show it outperforms sleep medication in the long run, and unlike medication, the benefits do not disappear when treatment ends. In many studies, improvements continue to strengthen for months after the program is complete. Now, not everyone has access to a CBT-I trained therapist. If that is your situation, digital CBT-I programs are a well-researched alternative. Apps like Sleepio and programs like CBT-I Coach, developed by the VA, have strong evidence behind them and are far more affordable or in some cases free. If you take nothing else from this video, take this. If you have chronic insomnia, CBT-I is the treatment you should be asking about. Intensive sleep retraining, ISR, is a lesser-known but genuinely impressive intervention for people who have difficulty falling asleep specifically. Unlike CBT-I, which unfolds over weeks, ISR is completed in a single extended session, typically around 25 hours, conducted in a clinical setting under supervision. Here is how it works. Over the course of that session, the person attempts to fall asleep every 30 minutes. Each attempt is a brief, supervised sleep opportunity. The repeated experience of successfully falling asleep over and over in a condensed time frame essentially re-teaches the brain that it can do this. It is exposure therapy for the bedtime experience. Research has shown that ISR meaningfully reduces insomnia severity and significantly improves sleep onset latency, that is, the time it takes to fall asleep. And these benefits have been shown to persist for up to 3 months following the single treatment session. That is a compelling result for something that is essentially a one-time intervention. For comparison, standard pharmacological sleep aids require ongoing use and carry risks of tolerance and dependence. ISR is not yet widely available outside of academic sleep centers and specialized clinics. But if you have tried CBT-I and still struggle primarily with falling asleep, it is worth asking a sleep specialist whether ISR is something you could access. Now I want to shift to a topic that surprises almost everyone when they first encounter it. There is a clinical context in which deliberately keeping someone awake is actually used as a treatment, not for insomnia, but for depression. And understanding this changes how we think about the relationship between sleep and mental health entirely. Depression and sleep deprivation have a well-known relationship. Each one makes the other worse. If you have ever gone through a depressive episode, you know that disrupted sleep is almost always part of it. But here is the part that most people do not know. In certain clinical settings, controlled sleep deprivation is used as a therapeutic tool for depression. And it works, at least temporarily, in a surprisingly high proportion of patients. Research shows that total sleep deprivation, staying awake for an entire night under medical supervision, produces measurable improvement in depressive symptoms in 40 to 60% of patients with major depressive disorder. That is a significant response rate, comparable to some antidepressants in short-term trials. Why would this work? The honest answer is that the exact mechanism is still being studied. But the leading hypothesis involves the brain's adenosine system and circadian rhythm dysregulation in depression. In depression, the body's internal clock often runs out of sync, what researchers call circadian misalignment. Controlled sleep deprivation may act as a kind of reset, forcing a phase shift in the circadian system that temporarily relieves the mood disturbance. Partial sleep deprivation, sleeping only during the first half of the night and then staying awake, produces similar effects and is somewhat easier to tolerate. Here is the important caveat. These improvements are often short-lived. For most patients, mood returns to its depressed baseline after they recover sleep, sometimes within 24 hours. This is why sleep deprivation alone is not a treatment for depression. It is most useful as a component of a broader protocol. Research suggests that combining controlled sleep deprivation with antidepressant medication, bright light therapy, or cognitive behavioral therapy can help sustain the initial mood improvement, essentially using the sleep deprivation response as a window to reinforce other treatments. The evidence on long-term outcomes for this combined approach is still developing. Systematic reviews have found mixed results, and researchers are actively working to identify which patients are most likely to respond and how to optimize the protocols. If you are managing depression and also struggling with sleep, this is a conversation worth having with your psychiatrist or prescribing provider. It is not a DIY intervention. Controlled sleep deprivation in a clinical context looks very different from just staying up all night at home. One important safety note: controlled sleep deprivation is not appropriate for everyone. For people with bipolar disorder, it can trigger a manic episode. This is a clinical protocol that must be supervised by a qualified provider who knows your full history. Please do not attempt this at home. But knowing it exists gives you something to ask about. The broader message here is that sleep and mood are deeply intertwined. Treating one supports the other. The approaches I am going to cover in this chapter are often dismissed as soft options, things people try before getting serious help. I want to challenge that framing. For mild to moderate sleep difficulty, these approaches are genuinely effective. For severe or chronic cases, they work best alongside CBT-I or medical treatment. None of them are substitutes for proper clinical care when that is what someone needs. But none of them should be dismissed either. Mindfulness-based interventions, particularly mindfulness-based stress reduction, known as MBSR, and mindfulness-based cognitive therapy, have a meaningful evidence base for sleep improvement. Here is why they work. Insomnia is often driven by a hyper-aroused brain, a mind that will not stop producing thoughts the moment you lie down. Mindfulness training does not suppress those thoughts. Instead, it changes your relationship to them. You learn to observe them without being pulled into them. The result is reduced pre-sleep cognitive arousal, which is one of the main perpetuating factors in chronic insomnia. Studies have shown improvements in sleep quality, reduced time to fall asleep, and decreased nighttime awakenings. For people whose sleep difficulty is driven primarily by rumination and anxiety, mindfulness is not a soft option. It is a legitimate clinical tool. Regular aerobic exercise is one of the most consistently supported interventions for sleep quality across the research literature. It improves sleep depth, specifically the slow-wave, deeply restorative stages, reduces the time it takes to fall asleep, and supports mood regulation. The effect is not immediate. In most studies, consistent exercise over several weeks produces meaningful sleep improvements. This is not the kind of fix that works tonight, but it is the kind that compounds over time. A note on timing. Vigorous exercise within 2 to 3 hours of bedtime can be stimulating for some people. Morning or early afternoon exercise tends to produce the most consistent sleep benefits. Aromatherapy, particularly lavender, has a more modest but real evidence base for sleep and anxiety reduction. It is not going to resolve chronic insomnia on its own, but for people with mild sleep difficulty or high pre-sleep anxiety, it is a low-risk, low-cost complement to other strategies. The mechanism appears to involve modulation of the autonomic nervous system. Lavender compounds may reduce sympathetic nervous system arousal, which is exactly what you want when you are trying to transition into sleep. And then there is sleep hygiene, the environmental and behavioral foundation that supports everything else. Consistent wake time every morning, including weekends. Avoiding caffeine after noon or 1 p.m., keeping the bedroom cool, dark, and quiet, limiting alcohol, which fragments sleep architecture even if it helps you fall asleep faster, getting natural light exposure in the morning. Sleep hygiene alone will not fix chronic insomnia. Research has shown this clearly, but as a foundation under CBT-I or any other treatment, it meaningfully improves outcomes. This chapter covers something that is genuinely new in sleep science, and genuinely surprising: the relationship between your gut and your brain and what it means for sleep. The gut and brain are in constant communication through a network of nerves, hormones, and immune signals called the gut-brain axis. We have known about this connection for some time. What is newer is the growing evidence that the composition of gut bacteria, the microbiome, directly influences brain function, including mood, cognitive performance, and sleep. Sleep deprivation, it turns out, is not just a result of poor gut health, it also causes it. Studies in both animals and humans have shown that sleep loss disrupts the composition of gut microbiota, reducing bacterial diversity and affecting species associated with metabolic and neurological health. On the therapeutic side, early research suggests that interventions targeting the gut microbiome, including dietary changes toward more fiber and fermented foods, probiotic supplementation, and in clinical research settings, fecal microbiota transplantation, may help alleviate some of the metabolic and neuropsychiatric effects of sleep deprivation. Specific findings include improvements in inflammatory markers, cortisol regulation, and even mood stability, all of which affect sleep quality. I want to be transparent here. This is an emerging field. The research is promising, but it is not yet at the level where specific clinical recommendations can be made with confidence. This is not something that has made it into treatment guidelines yet. What it does tell us powerfully is that sleep health is whole body health. Your diet, your gut, your metabolic function, and your brain are not separate systems. They speak to each other constantly. Treating sleep in isolation from the rest of how you live will always be a partial solution. We have covered a lot of ground. Let me bring it together into something you can actually use. If your sleep difficulty has been going on for 4 or more weeks and is affecting how you function during the day, the first step is a conversation with a healthcare provider to rule out underlying causes, particularly sleep apnea, depression, or another medical condition. If chronic insomnia is the diagnosis, CBT-I is the treatment to pursue first. Ask your provider for a referral to a CBT-I trained therapist, or start with a well-validated digital program while you wait for access. Layer in the supporting strategies: consistent wake time, morning light exposure, regular exercise, and a wind-down routine. These do not replace CBT-I, but they meaningfully support it. If you are also managing depression and your sleep and mood feel entangled, raise that specifically with your mental health provider. The interplay between sleep and mood has treatment implications that go beyond just prescribing a sleep aid. Here are 4 concrete things you can do this week. 1. Set a consistent wake time and commit to it for the next 2 weeks, even on weekends. 2. If you have chronic insomnia, look up digital CBT-I programs. CBT-I Coach from the VA is free. Sleepio has strong evidence and is increasingly covered by some insurance plans. 3. Download the free CareThrive Sleep Guide at carethrive.org. It covers sleep hygiene, sleep science, and how to talk to your provider about sleep, in plain language, at no cost. 4. If you have been struggling for more than a month and have not spoken to a provider, make that appointment. You do not have to figure this out alone. Sleep is not optional, and knowing how to treat sleep deprivation is not information that should be locked behind paywalls or buried in academic journals. CareThrive exists because everyone deserves access to clear, evidence-based health information, regardless of what they can afford, where they live, or whether they have a primary care doctor. If this video helped you, please share it with someone who needs it. Subscribe so you do not miss the next video, and leave a comment below. I read every one, and I would love to know what topics you want us to cover next. Take care of your sleep. It takes care of everything else.